Hello and welcome to our on-demand learning session, Lung Cancer Screening for Primary Care Teams, presented as part of MPRO's Michigan Cancer Control Initiative. My name is Julie Campbell, and I'm also joined by my colleague Elise Wilson, and we'll be facilitating this session. Because the Michigan State Medical Society is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. No one in control of content has any relevant financial relationships with ineligible companies to disclose. And to earn CME credit or certificate of participation, you'll need to view this webinar and complete an evaluation. So first, just a bit of background on MPRO. We are a nonprofit organization and a national leader in healthcare quality improvement and medical review. And we work with healthcare providers to promote adoption and use of evidence-based best practices to achieve healthcare quality goals. MPRO also represents Michigan in the Superior Health Quality Alliance under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. Our goal is helping healthcare get better with a commitment to improving quality, safety, and efficiency across the healthcare continuum. MPRO's Michigan Cancer Control Initiative incorporates 5 key strategies. So first, increasing community awareness for early detection. So sharing information and resources to support informed decision-making about screening. Next, evidence-based interventions. So sharing strategies and interventions that work to support cancer screening and early detection. Personalized technical assistance. So here we work one-on-one with practices to support their processes for cancer screening and prevention. And then leveraging EHR and data. So we also work with practices to identify where they are currently and what their goals are around cancer screening quality measures. And then provider and community education. So really bringing information and resources to care teams, which is the focus of today's session. In the lung cancer component of this initiative, we work with practices to improve tobacco use screening and counseling, and also processes for identifying and referring eligible patients to lung cancer screening. And the goals of this project component are to improve the identification of patients using commercial tobacco and those that are eligible for lung cancer screening, to increase care team knowledge and confidence around lung cancer screening eligibility criteria and processes for referring patients to screening, and also to support providers and care teams in areas with high prevalence of commercial tobacco use and lung cancer incidence and mortality. This activity is supported in part by the Michigan Department of Health and Human Services. So here are our session objectives. By the end of this session, we hope that you'll be able to explain statewide prevalence of commercial tobacco use, lung cancer incidence and mortality, and the importance of early detection. We hope that you'll be able to describe lung cancer screening recommendations, eligibility criteria, benefits, risks, and costs, and understand how to identify eligible patients and conduct counseling and shared decision-making visits, identify quality measures that will be impacted by referral processes for lung cancer screening, and also find strategies and resources for promoting lung cancer screening and commercial tobacco cessation. So why should we talk with patients about lung cancer screening, and why should it be a priority? Lung cancer continues to be the leading cause of cancer death in the US. And while survival is improving, we've seen a 33% improvement in the 5-year survival rate over the last 10 years. Data shows that awareness of lung cancer is actually still very low. The 2021 Lung Health Barometer is a nationally representative survey conducted by the American Lung Association, and that looked at awareness, attitudes, and beliefs of 4,000 Americans about lung cancer. And what they found was that increases in survival rate are due to the life-saving potential of lung cancer screening and support of advancements in research around better treatment options. Greater awareness of lung cancer screening is key to encouraging screening and also reducing stigma around lung cancer. We also need more awareness. So 29% of Americans know that lung cancer is the leading cancer killer of women and men, and this is an 8% increase from the 2020 survey. 69% of adults have not spoken with their doctor about their risk for lung cancer, and only 44% are concerned that they might get the disease. Only 36% of survey respondents knew that lung cancer screening is now available for early detection of the disease. And despite the potential to save lives, only about 5% of those eligible for lung cancer screening have been screened. So talking with patients and raising awareness about screening is critical to saving lives. There was also a morbidity and mortality weekly report that came out in early 2020 from the CDC on the importance of lung cancer screening to save lives. So this report identifies that lung cancer is the #1 cause of cancer deaths, and also that more cancer screening is needed. The report summarizes an assessment of screening prevalence from 10 states in 2017, which found that overall 1 in 8 people aged 55 to 80 met the screening criteria at that time. And among those meeting the screening criteria, 7 out of 8, so 87.5%, did not report receiving screening. Of those meeting the screening criteria, nearly half, 5.6%, were former smokers. Michigan wasn't one of these 10 states, though according to MDHHS, only 16% of eligible adults in Michigan report ever being screened, and 6% report screening in the last year. The findings from this report really suggest an important opportunity to impact community awareness of lung cancer screening by talking with patients who may be at risk, and especially on the part of primary care teams as a trusted source of information and care. So knowing that there's this need on a national scale to talk more with patients about lung cancer screening, now we'll go ahead and get into more of the burden of lung cancer and the risk factors in our statewide communities. Here we have percentage of adults who are current smokers by county based on 2018 behavioral risk factor surveillance system data, with lower prevalence starting at 15% in light blue and then darkening as percent increases up to 29%. Our statewide prevalence during this time was 20%. And based on data from 2017 to 2019, our statewide prevalence is 19%. So this is significantly higher than the national rate of 15%. We know that tobacco is one of the strongest cancer-causing agents and that smoking is the leading cause of lung cancer. There's also evidence showing that risk of lung cancer from smoking cigarettes increases with number smoked per day and number of years smoked. So looking at this map, hopefully you're able to pinpoint your location to see where the population that you serve is falling within this range of smoking burden. And highest burden areas are in darker blue. So we see these areas of higher prevalence in the eastern and mid to northern lower peninsula, and then in the upper peninsula as well. Taking this risk factor of commercial tobacco use from a general population snapshot and looking at trends in use, we do see a decrease in adult cigarette use from 2011 to 2020. So we see that decrease from 23.3% to 18.4% in 2020. We also see a decrease in adult smokeless tobacco use from 4.4% in 2011 to 2.9% in 2020. And then adult e-cigarette use. So when data was first starting to become available in 2016, this was 4.9%, and we've actually seen that increase to 6.4% in 2020. And then comparing youth tobacco use from 2017 to 2019, we see decreases in cigarette use from 10.5 to 4.5%, and in smokeless tobacco use from 6.3% to 2.9%. And we also see an increase in e-cigarette use from 14.8 to 20.8%. So the decreases that we're seeing in adult cigarette and smokeless tobacco use are encouraging, though when the data is broken down by demographic factors, which we can see in this chart below, we see that there are populations experiencing a higher burden. So the Native American population has the highest burden of cigarette use, 42.6% indicated in that green bar, as well as smokeless tobacco use in blue and e-cigarettes represented in orange. Individuals identifying as bisexual or gay report higher cigarette use, 39.1% and 29.9% respectively, compared to those identifying as straight. And the same goes for e-cigarette use as well. And then looking geographically, we see slightly higher cigarette and smokeless tobacco use in rural populations compared to urban, while urban populations have a higher burden of e-cigarette use. Moving from tobacco use to lung cancer incidence and mortality, the map on the left is showing lung cancer incidence from 2014 to 2018 in Michigan, with lower rates starting at 39.1 in light yellow and darkening blue as rates increase up to 109.6 per 100,000. The overall state lung cancer incident rate is 62.9 per 100,000. There are quite a few counties exceeding the state rate, especially around the mid to northern lower peninsula. Incidence has decreased over the last 10 years from 72 in 2008 to 59 per 100,000 in 2018. And then the map on the right shows lung cancer mortality rates, and this is from 2015 to 2019, with lower rates starting at 23.6 in light orange and darkening red with increasing rates up to 73.7 per 100,000. The statewide lung cancer mortality rate is 42.3 per 100,000. And again, we see a number of counties with the highest rates in the northern lower peninsula, concentrating in the northeast, as well as in the upper peninsula. Mortality has also decreased over the last 10 years from 54 in 2009 to 39 per 100,000 in 2019. Again, hopefully you're able to visualize where your location is as far as incidence and mortality. Those areas with higher incidence indicate that cases are being detected, though if we're also seeing high mortality rates, it may be that cases are being detected at later stages, which we'll talk about more in just a moment. So where does Michigan rank in terms of new cases of lung cancer nationally? The American Lung Association's State of Lung Cancer report shows that the burden of lung cancer in each state, and this graph from the 2021 report shows that Michigan's rate of new lung cancer cases, 63, is significantly higher than the national rate of 58 per 100,000, which is shown in green. So here, Michigan is displayed in the orange bar. So we're ranking 35th among all states, and that places us in the average tier, kind of bordering on the below average tier. Over the last 5 years, the rate of new cases improved by 9%. Again, this improvement is encouraging, though we are still seeing disparities. Among Black Americans in Michigan, the rate of new lung cancer cases is 69 per 100,000. This is significantly higher than the rate among Black Americans nationally, which is 60, and also significantly higher than the rate of 64 per 100,000 among white Americans in Michigan. 19% of lung cancer cases are diagnosed at an early stage. This is significantly lower than both the rate of Black Americans nationally at 21% and the rate among white Americans in Michigan, 23%. Looking at lack of lung cancer treatment for Black Americans in Michigan, 23% did not receive any treatment. This isn't significantly different from the rate among Black Americans nationally at 23%, but it is significantly higher than the rate of 18% among white Americans in Michigan. 16% underwent surgery. So this is significantly lower than both the rate of Black Americans nationally at 17% and the rate among white Americans in Michigan at 20%. Among Indigenous peoples, so American Indians and Alaska Natives in Michigan, the rate of new lung cancer cases is 110 per 100,000. This is significantly higher than the rate among Indigenous peoples nationally, 41, and significantly higher than the rate of 64 per 100,000 among white Americans in Michigan. 16% of lung cancer cases are diagnosed at an early stage. This is significantly lower than both the rate of Indigenous peoples nationally at 22% and the rate of 23% among white Americans in Michigan. And then looking at lack of lung cancer treatment for Indigenous peoples in Michigan, 22% did not receive any treatment. And this isn't significantly different from the rate among Indigenous peoples nationally at 23% or the rate of 18% among white Americans in Michigan. 13% underwent surgery. This is significantly lower than both the rate among Indigenous peoples nationally at 17% and the rate among white Americans in Michigan at 20%. Building on lung cancer incidence and mortality, we see that survival is largely impacted by stage at diagnosis. So in this chart, the largest green portion indicates that almost half of lung cancers are being detected at distant stages, so 48.3%, which involve lymph nodes and other organs and are more difficult to treat. 22% are detected at regional stages where there's extension beyond the limits of the organ, and 20.8% at localized stages where there's no spread beyond that organ. If we look at 5-year survival by stage, we see consistently lower 5-year survival rates for diagnoses at the distant stage. So that was that largest proportion in the chart that we just saw. And survival rates increase when diagnosed at the regional stage and are highest in the localized stages. But here again, we see disparities, with Black males having lower rates of survival in most of the known diagnosis stage categories. So the takeaway here really is that early detection is key for increasing survival, which also speaks to the need for timely identification of patients at high risk and referral to screening. This graphic comes from the American Lung Association's 2021 State of Lung Cancer Report, showing stage at diagnosis and 5-year survival rates nationally. This is another good representation of 5-year survival being higher at earlier stages of diagnosis. In looking at how Michigan compares, in Michigan, 23% of cases are caught at an early stage, so that's significantly lower than the national rate of 24%. Michigan also ranks 39th of the 49 states with data on diagnosis at an early stage, and that puts us in the below average tier. In the past 5 years, the early diagnosis rate in Michigan has improved by 41%. So here's one example of early detection contributing to increased survival in a healthcare system that established a pulmonary nodule clinic, or a PNC, to review CT scans. So the authors point out that pulmonary nodules are a common incidental finding and are often how lung cancer is discovered. Their goal was to determine if creating a pulmonary nodule clinic, a PNC, in a community healthcare setting would contribute to earlier stage of diagnosis. So just a note too, PNCs bring together thoracic surgeons, pulmonologists, radiation, medical oncologists, interventional radiologists, and pathologists who collaborate to manage pulmonary nodules by creating comprehensive, individualized plans of care. So in this study, they did a retrospective review of pulmonary nodule clinic patients from 2010 to 2015, diagnosed with lung cancer, and analyzed stage at diagnosis compared to lung cancer patients in their healthcare system outside of the PNC, as well as national data. What they found was that a higher percentage of stage 1 lung cancers were diagnosed through the PNC, so 54.3%, compared to cancers diagnosed outside of the PNC, 28.4%. They concluded that lung cancer survival is directly related to stage at diagnosis, and that earlier identification of malignant nodules can lead to earlier diagnosis and increased survival. Here's one of the figures from the study showing that lung cancer stage at diagnosis for PNC patients on the left, and then non-PNC patients in the middle, and then nationally, right. So the blue bars represent cancers diagnosed at localized stages, orange indicates regional stages, and gray indicates distant stages. So here, a higher proportion of cancers were diagnosed at localized stages among PNC patients, and a higher percentage of regional and distant stages at diagnosis in non-PNC patients. The authors do point out that the data supports modifying risk factors like tobacco use to improve mortality, and also supporting that PNCs and lung cancer screening programs accelerate the evaluation and treatment of lung cancer. And we know that early detection of lung cancer is key to increasing survival. So when we think about the populations in need of lung cancer screening, identifying patients who are eligible really is key for timely referral and screening. There have been recent updates to the criteria for screening eligibility, and so it's expected that the prevalence of those who are recommended and need to be screened will increase. Here we have data on the population in Michigan in need of lung cancer screening, and this is based on 2016 and 2017 Michigan Behavioral Risk Factor Survey data. At this time, statewide, 2.9% of adults were meeting US Preventive Services Task Force recommended eligibility criteria for screening. Though we see this vary by region, with higher eligibility prevalence in Northeast Michigan at 7.6%, 4% in the Upper Peninsula, 3.8% in East Michigan in the Thumb area, and 3.5% in the Northwest. Again, with recent updates to USPSTF recommendations for screening, the prevalence of people eligible and in need of lung cancer screening is expected to increase. And we'll talk a bit more about these updated recommendations in a bit. According to the American Lung Association's 2021 State of Lung Cancer report, in Michigan, 8% of those at high risk were screened, which is significantly higher than the national rate of 6%. And Michigan, again here represented in orange, ranks 11th among all states, putting us in the above average tier. While our screening rate for those at high risk is good, the early diagnosis rate in Michigan actually falls into the below average tier, meaning that we still have work to do to make sure that more of those at high risk for lung cancer are being screened to detect cancer earlier. And we'll talk a little bit more about what high risk means in just a bit as well. So hopefully throughout the previous slides, you were able to find your county or your region on those statewide maps, and also consider your patient populations when looking at that data broken down by demographics. Getting a little bit more specific to the practice level here, as part of our work with clinics around processes for tobacco cessation counseling and referrals to lung cancer screening, one of the resources that we provide is a lung cancer screening practice snapshot, which we have an example template of here. So this is a resource that highlights the clinic name, the practice's county, including that county's smoking prevalence and lung cancer incidence data, and then also featuring practice-specific metrics for tobacco cessation counseling, lung cancer screening referrals, and also patient population demographics. And then below in the middle, you'll also see information for the facility that practice is referring to for lung cancer screening. So this resource is meant to help clinics to see their patient populations that are at risk for lung cancer at a glance, and to be able to take action towards timely referral to screening. So if you're interested in this resource, we would be happy to create one of these tailored to your practice. Feel free to contact us and we'd be happy to do that. So now we'll get a little bit more into information on low-dose CT for lung cancer screening, specifically screening, test effectiveness, reimbursement, and coverage. So first, what is low-dose CT lung cancer screening? This is a non-contrast CT scan performed on patients who are at risk of developing lung cancer. So it may be known by a few different names: low-dose CT, helical or spiral CT, and LDCT. So during this session, we'll be referring to it as LDCT. LDCT uses X-rays to get a multiple image scan of the chest in about 7 to 15 seconds, compared to standard chest X-ray, which produces a single image of the chest where anatomic structures overlie one another. Screening for lung cancer exposes a person to a low dose of radiation, though this type of scan uses less radiation than a regular CT scan. If the screening test is positive, additional testing may involve higher doses of radiation. This chart is helpful for comparing the amount of radiation exposure from an LDCT scan compared to other sources of radiation, and also could be useful for patient education as well. So here it lays out different sources measured in millisieverts, the amount of radiation absorbed by the body. So we can see that LDCT for lung cancer screening here is shown at 1.4 millisieverts. Below that, we see 10 hours of air travel, chest X-ray, and mammogram. And then exceeding that, we see average background radiation in the US over 1 year at 3 to 5 millisieverts, and then a diagnostic CT at 7. At this time, researchers don't know how exposure to radiation from LDCT scans and additional diagnostic imaging may affect people, though the benefit of potentially finding a treatable cancer appear to outweigh the radiation exposure risks of the procedure. What we know about LDCT versus chest X-ray for lung cancer screening largely comes from the National Lung Screening Trial, or the NLST. This study was needed as lung cancer is the leading cause of cancer-related death in the US, and most lung cancers are detected when they cause symptoms. By this time, the disease is often already spread outside of the lungs. So researchers were looking to develop methods to screen for lung cancer before symptoms became evident. This study compared two ways of detecting lung cancer, so LDCT versus standard chest X-ray. It enrolled over 50,000 former or current heavy smokers, and that was defined as 30 pack years. And we'll get a little bit more into pack year calculations in just a bit too. And then participants were ages 55 to 74. Participants were then randomly assigned to 3 annual screenings with either LDCT or chest X-ray. And what they found was that participants who received LDCT scans had 15 to 20% lower risk of dying from lung cancer than participants who received standard chest X-rays. They also found that adenocarcinomas and squamous cell carcinomas were detected more frequently at the earliest stage by LDCT compared to standard chest X-ray. Additionally, the Nelson trial looked at reduction in lung cancer mortality in groups receiving screening with LDCT versus no screening. So this study included over 15,000 participants, mostly men, at high risk for lung cancer. And these were participants ages 50 to 74 with a smoking history of more than 15 cigarettes per day. So 3/4 of a pack for more than 25 years, or more than 10 cigarettes per day, about half a pack for more than 30 years, and who were current smokers or had quit within the last 10 years. Screening group participants underwent initial screening and then subsequent screenings at intervals of 1, 2, and 2.5 years. What they found was that among men, there was a 24% reduction in lung cancer mortality in the screening group compared to the no screening group. And at 10 years of follow-up, there were 2.5 deaths per 1,000 person years in the screening group compared to 3.3 in the no screening group. This trial provides evidence for benefit of screening for lung cancer with LDCT in younger people with lighter pack year smoking histories. Based on these and other data, the United States Preventive Services Task Force, or the USPSTF, finalized updated recommendations for lung cancer screening in March 2021, and the previous recommendation was finalized in 2013. These updated recommendations expand and essentially double the number of people eligible for screening by lowering the eligible age and including those with shorter smoking histories. So the current recommendation is for annual screening for lung cancer with low-dose computed tomography, LDCT, in adults aged 50 to 80 years who have a 20 pack year smoking history and currently smoke or have quit within the last 15 years. Lung cancer screening with LDCT is designated as a grade B recommendation by the USPSTF, which means that the service is recommended as there is moderate certainty that the benefit of the service is moderate to substantial. Comparing the previous and now archived USPSTF recommendation finalized in 2013 to the one that was updated in 2021, we want to highlight some of the differences in screening eligibility criteria. So first, with age, with the current recommendation, people are eligible starting earlier, so at age 50, compared to the previous recommendation, which started at 55 years. Also for pack years, the recommendation now includes 20 pack year smoking histories, so fewer pack years are required to be eligible compared to that 30 pack year previously. There are consistencies between the previous and current recommendations as well. So the criteria still include those who are currently smoking or have quit within the last 15 years. And it's also still recommended to stop screening when a person has not smoked for 15 years or in cases of limited life expectancy or willingness to have curative lung surgery. This expanded eligibility criteria that we see with the updated recommendations means that more people will be eligible for screening, and it will also help to narrow some of the disparities that have existed in screening, especially among women, Black males, and Native Americans, by making earlier screening and detection more possible. As lung cancer screening with LDCT is a grade B recommendation from the USPSTF, Medicare and many other payers do cover it as a preventive service at no cost for individuals meeting eligibility criteria. It will take some time for all insurers to incorporate these recently updated criteria into coverage. So this is definitely something that we recommend checking back on with insurers. If a patient does want to complete lung cancer screening but doesn't meet eligibility criteria for their insurance, there will likely be a cost for them to have an LDCT scan. Without insurance coverage, the cost can range from $100 to $400 out of pocket, and this cost does vary. So again, we recommend getting in touch with the specific screening facility for specific pricing. So a little bit more on coverage. The American Lung Association has a couple of great resources on coverage for lung cancer screening. And so we pulled this information together into a summary table of known coverage details by health plan. We do want to note that coverage will depend on patients meeting the screening eligibility criteria that their plan covers and the patient being referred through the proper processes. But to summarize, across the top, you'll see the different payers. So employer-sponsored plans, Medicare, state health insurance marketplace plans, individual plans, and Michigan Medicaid fee-for-service. And then along the left side are coverage details. So any differences from the eligibility criteria laid out in the USPSTF recommendation, any expected cost sharing, additional costs, and additional notes. For differences from USPSTF eligibility criteria, if patients are 55 to 80 years old with a 30-pack year smoking history, and they're current smokers or have quit within the last 15 years, their plan should already cover screening, as this is aligned with the previous 2013 USPSTF recommendation. The difference we want to point out is that Medicare covers screening for those 50 to 77, according to the National Coverage Determination that was announced in February 2022. Michigan Medicaid fee-for-service coverage has historically aligned with USPSTF eligibility criteria, and payers will be changing their coverage criteria based on the newly updated recommendations from USPSTF. So again, to that eligibility criteria of 50 to 80 years old with 20-pack year smoking histories. So that will be something to keep checking back on. Looking at expected cost sharing, generally there should not be cost sharing, so copays, coinsurance, or deductibles across these types of health plans, with a note that there may be a charge for facilities considered to be out of network. Screening has been covered without cost sharing under Medicaid expansion. For additional costs, there may be additional costs for screening, like facility fees that are not covered. So confirm if the facility and provider are in network to avoid additional costs. And then just a few additional notes. For employer-sponsored and individual plans, if the plan is grandfathered under the Affordable Care Act, it may not be required to provide coverage for lung cancer screening without cost sharing. Medicare Advantage plans may opt to cover screening for those over the age of 78. And for Medicaid, no prior authorization is required, though coverage may vary between fee-for-service and managed care plans. And then just a couple notes for employer-sponsored and state health insurance marketplace plans. As a result of the Affordable Care Act, most private insurance plans will need to update screening coverage policies to reflect the updated USPSTF guidelines for plan years after March 31st, 2022. But patients should check with their insurance plans to see if coverage is already available. Again, if patients are 55 to 80 years old with a 30-pack year smoking history and are current smokers or have quit within the last 15 years, their plan should already cover screening. For individual plans, some plans sold directly by insurance companies have to comply with the standards set by the Affordable Care Act, in which case the plan would follow the insurance coverage requirements for employer-sponsored plans. However, there are many types of plans that may not have to follow these standards and so may not cover lung cancer screening. The patient should contact their plan directly to find out what coverage looks like for them. So again, this is just a high-level summary. The best source of truth will be to contact the plan for specific coverage details. And now I'm going to go ahead and hand things over to Elise to talk more about identifying eligible patients.
So now we are going to talk about how to identify your eligible patients using the new USPSTF criteria, as well as using your EHR and documenting these elements for identifying and referring those patients for low-dose CT scan. So in early February, CMS released its national coverage determination to align with the USPSTF recommendations and expand eligibility for people with Medicare to get low-dose CT. They lowered the starting age, as Julie had mentioned, from 55 to 50 years, as well as reduce the tobacco smoking history from at least 30 pack years per year to at least 20 pack years per year. So overall, to qualify for low-dose CT lung cancer screening, patients must meet the following criteria. They must be 50 to 80 years of age. For Medicare coverage, that includes people 50 to 77 years. They must be asymptomatic or otherwise showing no signs or symptoms of lung cancer. They must have a tobacco smoking history of at least 20 pack years. So what does this mean? 1 pack year equals 1 pack per day for 1 year. So 20 pack years means a person has smoked 1 pack per day for 20 years or 2 packs per day for 10 years, etc. Lastly, the person must be a current smoker or have quit within the last 15 years. So if calculating pack years is something new to you or your team, there are some tools out there that you can use. This screenshot is from shouldiScreen.com, where it allows you to plug in how many years the person has smoked and on average how many cigarettes they smoke per day. And it gives you the guidance that 20 cigarettes are in a pack. So a person may give you a number of cigarettes, they may give you the number of packs, and you're able to transfer that into this input. And then it would be able to calculate that for you. We also linked you to smokingpackyears.com. That's another tool you can use, and it allows you to enter different forms of tobacco use as well. Your EHR may be another tool that you can use to calculate pack years, and it may do that for you. This is a screenshot from Epic where, as you're documenting a person's smoking status and start and quit dates, it also prompts you to input packs per day in years, and then it offers that pack years calculation too. So this is something that also you can use if your EHR has that capability. When you are identifying eligible patients for lung cancer screening, your quality measures can also be impacted in a positive way. For example, when you're assessing a person's tobacco use to determine their eligibility, you're providing tobacco cessation counseling if they're a current smoker, and you're documenting that within your EHR, your team is also improving your quality measures. This HEDIS measure is one of the measures that can be impacted. The HEDIS measure medical assistance with smoking and tobacco use cessation. We're identifying those current smokers that are ages 18 and older, and you're advising tobacco users to quit and discussing cessation medications and strategies. Another measure that can be impacted is the CMS measure, preventative care and screening tobacco use, screening and cessation intervention. Again, where you're identifying those patients 18 and older who are tobacco users, and then providing that tobacco cessation intervention for current smokers or current tobacco users. For tribal health clinics, we also want to include the GPRA measures that can also be affected by identifying patients for lung cancer screening, the tobacco use and exposure assessment measure, where patients are being screened for tobacco use during that reporting period. They're being identified as current tobacco users, as smokers of other substances, and exposed to ETS during the reporting period. And then the tobacco cessation measure, where patients who receive tobacco cessation counseling or receive a prescription for tobacco cessation aid or quit their tobacco use anytime during the reporting period. Once a person is identified as eligible for lung cancer screening, there are important steps to take during that referral process, which includes the shared decision-making visit that we will talk about now. The national coverage determination that I had mentioned earlier that was released by CMS in February also simplifies requirements for the counseling and shared decision-making visit. They continue to support the need for the shared decision-making visit, covering specific information that we'll talk about in just a moment, but they've modified requirements by first removing the specificity on the type of provider who furnishes the shared decision-making visit. And they include other health practitioners that can provide the shared decision-making visit, such as health educators. They also removed some specificity around documentation, stating that the medical record should reflect the necessary elements. All eligibility should be captured in the medical record, like the person's age, their smoking history, etc. But if your EHR is not auto-calculating those PAC years, which is also part of eligibility determination, then make sure that that is noted somewhere within the patient's chart. They also removed the requirement for a written order, as many referrals are transmitted electronically. And overall, these changes are with the intention to increase flexibility, to reduce provider burden, and broaden access to low-dose CT. So what needs to be covered during this counseling and shared decision-making visit? First, during this shared decision-making visit, there needs to be the use of one or more decision aids, and we will show you a couple examples, as well as at the end, link to a lot of resources that have some decision aid tools. Second, the person who is furnishing this visit with the patient must talk about the importance of adherence to annual lung cancer low-dose CT screening. So once that person gets their initial screening, they will then do annual lung cancer screenings as long as they are eligible. They also need to discuss the impact of comorbidities or the person's ability or willingness to undergo diagnosis and treatment. You can talk through things like benefits and harms of screening. Like Julie had mentioned, radiation exposure may be a concern for someone. So using a visual around how radiation exposure compares to everyday exposure. Also talking about follow-up diagnostic testing and what that may look like if applicable, as well as the chances of overdiagnosis and treatment. The person also must be counseled on the importance of beginning or maintaining tobacco smoking abstinence, and when appropriate, also be provided information about tobacco cessation interventions. The shared decision-making visit must occur before that person's initial lung cancer low-dose CT screening. The CPT code to bill for this visit, you see here the G0296 code, this definition being that this is a counseling visit to discuss the need for lung cancer screening using low-dose CT scan, and that this service is to determine a person's eligibility and that shared decision-making conversation and visit. This CPT code may be billed on the same day as a medically necessary E&M visit or annual wellness visit with the 2.5 modifier. This visit is not subject to coinsurance or deductibles, and the code is listed as permanent telehealth code and is payable in the facility and non-facility setting. Another thing to note is although the shared decision-making visit has to happen before the initial screening, it is then optional to provide the visit for subsequent annual lung cancer screenings, but it is reimbursable. So you do not have to go through the counseling and shared decision-making elements after that initial screen for the yearly screens after, but you can, and you can be reimbursed for that. The counseling and shared decision-making visit procedure code, that G code, must be billed with one of these ICD-10 diagnosis codes to show that personal history of tobacco use and nicotine dependence. So you can see here, there's a code specific for former smokers, and then a few codes for current smokers, and we've linked you to that list of current smoker diagnosis codes as well. This is really important to make sure that those two are billed together, again, to show the history of tobacco use and nicotine dependence, and that will ensure that the patient receives the screening with no unexpected out-of-pocket costs, and that you are also reimbursed appropriately for that counseling and shared decision-making visit. Once the patient and provider complete that shared decision-making visit and the patient agrees to lung cancer screening, an order or referral for lung cancer screening would then be made. The accredited lung cancer screening facility may have their own form to fill out, but most of them require the following elements: the person's date of birth, their calculated pack-year smoking history, the number. So again, we're looking for 20 or more. Their current smoking status, or for former smokers, the number of years since they've quit smoking. And again, we're looking for the number 15 or less. A statement that the patient is asymptomatic, and the NPI of the ordering practitioner. They may also ask if this is an initial or subsequent scan as well. So you determine a person is eligible, you go through that shared decision-making visit and provide the referral to get their screening completed. Where do you send a patient for their low-dose CT scan? The American College of Radiology has a list of all ACR designated facilities. This means that these facilities are considered the gold standard, and they have the lung cancer screening center badge that you see here. But it's not the limited list of facilities that you can refer your patients to. There's about 150 facilities that have the capability to provide that low-dose CT scan, and that is the list linked here. And then the map that you see here are those gold standard facilities. There's an actual search on the website that you can search within a certain mile radius and see what is nearby. But again, there are additional facilities that can provide that scan for your patients. So once that person receives their scan, what do you do next, especially with those abnormal results? So we are using the criteria from the ACR lung RADS. And it's important to know that about 80 to 90% of scans are negative or benign. So this means that either no nodules are detected, there are nodules detected, but they are definitely benign, or there are nodules that have a very low likelihood of becoming active cancer due to their size or lack of growth. So the next steps here would be to write an order for an annual scan if that person still fits in the eligibility criteria. So they're still in that age range, they're still in the smoking pack year number or former smoker time range. 10 to 15% of scans have positive findings. So this means that there's a nodule detected and it's at a certain size and or varying solid components. So the next steps here would be to write an order for a nodule CT 3 to 6 months after that low-dose CT to assess if there's any growth or any change in solid component. And then 5% of scans are considered suspicious findings. So this means that additional diagnostic testing and or tissue sampling is recommended. So the next steps here is to discuss the findings with the patient and refer them to a specialist for the additional testing. So next, we're going to talk about a few evidence-based interventions that you can use to drive lung cancer screening forward. Client reminders are strategies to remind your patients that they are due or overdue for screening. Reminder messaging can be in the form of letters, postcards, phone calls, patient portal messaging, as long as your patients are being reminded outside of the clinical setting, outside of their visits with you all. So this happens typically at home. Reminders can also be effective when the messaging is tailored to your patient population. So if you have a patient population that primarily speaks Spanish, providing reminders in your patient's preferred language is going to be much more effective, as well as cultural considerations when tailoring your messaging. The American Cancer Society has really helpful and straightforward resources that you can include in your reminders, and they have resources in various languages. You can see here, there's a nice example of what a reminder letter would look like, and you can pull from the verbiage here to create your own, whether that be in a letter or a portal messaging. And you can even include a nice fact sheet with your letters so that patients can get a little bit more information aside from that they are due or eligible for this screening. Provider reminders are prompts for your providers that a patient is due or overdue for screening during their visit. We know there's a lot to address when seeing patients, so provider reminders are helpful as an extra visual cue for providers to check a person's eligibility or their screening status. This can be in the form of a clinical decision support alert in your EHR, or a physical cue like a colored sticky note on a door of an exam room, or attaching this checklist on top of all the other items that you're bringing in to the exam room to remind your provider that this person meets a lot of this criteria, and to have them go through this process of determining that person's eligibility and facilitating that counseling and shared decision-making visit if there's time for that. Patient education in small media is another strategy to help bring awareness to your patients as what screening is and why they are eligible or why they should be screened. There's a lot of resources that we're going to link at the end, which will have a lot of great things that you can use for patient education as well as provider education. The last strategy to promote lung cancer screening we wanted to discuss is establishing a physician champion. As we've worked with clinics on their lung cancer screening referral processes, we saw how important it was to have someone really championing the program to drive screening forward in their clinics. Some common best practices that we found that the champion provided was talking with fellow physicians about lung cancer screening and the importance of referring patients to a low dose CT and what that referral process could look like. They've also formed a steering committee to promote progress and problem solve any issues. And they also help identify what patient barriers are to screening and what education and strategies can be developed to help overcome those barriers. So when you're thinking about a physician champion and looking kind of at this discussion question, is there someone right now in your practice that is serving as a champion for lung cancer screening? If not, who could that be? And what could their roles be to really make sure that you all are referring patients to be screened for lung cancer? So lastly, we are going to talk about resources for tobacco dependence treatment and lung cancer. There are a few different avenues that you can go down to refer patients and support them in tobacco dependence treatment. If you're part of a health system, there may be a tobacco dependence treatment program available to your patients who are part of that health system. There also may be some programs in your community that you can refer patients to. If not, there are some other programs out there that have a more virtual format. So American Lung Association's Freedom from Smoking Group Quit program is one of those. Michigan Tobacco Quit Line is another. And we've also linked you to a list of local resources that you can see if there are any in your area, any in-person or more local programs. And then the American Indian Commercial Tobacco Program is another great program that you can refer patients to. So we're going to go a little bit more in depth for a few of these. The Michigan Tobacco Quit Line is a free quit program for anyone who uses any type of tobacco product. They offer personalized coaching available 24/7, and this can occur by phone, email, and texting. And they really help a person make a quit plan and set a quit date, identify their tobacco triggers and manage cravings, and strategize around getting back on track after relapses. They also offer nicotine quit medications, and there are free nicotine quit medications for eligible patients. Lastly, they offer membership in an online community, which can be really helpful and supportive for someone who is trying to quit. There are different ways that you can refer patients to the Quit Line. There is a provider web referral where you can go online and enter your clinic and patient's information and preferences. They also have an e-referral option where you can send the referral through your EHR in a secure two-way communication way. It's just important to note that the Quit Line must be set up in your EHR before you are able to do that. And then lastly, there is a fax referral option, and you can see the form on the right where you write in those sections and fax it over to the Quit Line. The American Indian Commercial Tobacco Program is another effective program you can refer patients to. This program has a special focus on helping Native Americans quit smoking while preserving traditional tobacco and keeping tobacco sacred in their culture. So they offer similar formats in terms of support, as well as how to help people quit smoking. They have a couple different options to get coaching. They have a phone and online coaching hybrid option. And then they also offer phone coaching only and online coaching only. And like I had mentioned, they help someone set those quit dates, tell their support system that they're quitting, preparing for cravings and triggers, etc. So we've also linked you to their website for more information, how a person can enroll or how a provider can refer someone. So this is the resources I had mentioned earlier. And there are a couple resources that we've actually pulled throughout our presentation. You see here the University of Michigan website, shouldiScreen.com. That is where we talked about the calculator for PAC years. Their whole website is really dedicated to getting more information on lung cancer screening. There are quizzes that people can fill out. There's a lot of information about lung cancer screening. So this is something that you can definitely point your patients to if they want to get a little bit more information before they commit. The National Cancer Institute, American Cancer Society, American College of Radiology, and American Lung Association are also great resources to use for both provider and patient education. They have decision aid tools that you can use during that shared decision-making visit. They also just have additional information around shared decision-making visits and the elements to cover there. The American College of Radiology is the website that I had mentioned around lung cancer screening facilities that you can do the search in your area, as well as other lung cancer specific resources that you can use. And lastly, the Michigan Cancer Consortium has a lot of compiled resources that are very helpful for those conversations and for that education. The last resource I wanted to highlight has actually been developed by our organization, MPRO. And this is a really great, easy tool to use when identifying a person's eligibility. There's a patient-facing version and a provider version where it really guides you through the questions as if you're asking them yourself. All of the yeses and the orange responses lead you to that the person is eligible for lung cancer screening. And if they're not quite eligible, whether they aren't at the quit years number or they're not in the age range, then it guides them to some other next steps, like contacting the Michigan Tobacco Quit Line or that lung cancer screening is not currently recommended. If you feel like this resource would be really helpful for your practice, you can reach out to us and our contact information is on the next slide and we can send this over to you. We can also personalize it to your needs. So if you have a local program for tobacco dependence treatment, we can also input that in this resource so that your patients are aware of it, as well as your providers on the provider version. We would really appreciate your feedback on this on-demand webinar. What was helpful? How can we improve? On the session landing page on our website, please complete the evaluation at that first link to provide your feedback. To claim continuing education credit, please use the second link that is on the landing page. And you can also see the links here on these slides. If you have any questions, if you need any resources, or if there are some links that are embedded in the slides that you don't have access to via this on-demand webinar, you can reach out to Julie or you can reach out to me and we would be happy to assist you. Thank you so much for listening and we look forward to hearing from you.